Good morning to you once again. Today we are going to discuss about airway obstruction, which is a very important aspect of basically in trauma, airway obstruction. The first thing which we have to see in airway obstruction is that patient, we have to find out whether the patient is breathing or not, right? This is the first step in the management of a polytraumatized patient. A patient who has got multiple injuries, he may be conscious or he may be unconscious, right? So, to assess the severity of injury in a patient, there is a system called prioritization of the injuries, and this management comes under, first of all, whenever the patient comes to you, first and foremost is the primary survey and the resuscitation. What did I say? You may get 100 patients, you may get one patient. If you get a severely injured person, a single person, you have to allot him the priority which part is to be tackled first. Because if a person who has got a polytrauma and I start treating him his leg injury, patient might die, because you have to allot a priority. Priority means which organ is to be tackled first, which is killing the patient. You get my point? So see, but when you have mass casualties, you are a single doctor in a periphery, and DM tells you that 200 patients will be coming and you are the only doctor, then you have to allot the priority. Which patient is to be managed first? A person who is comatose, who is unconscious, he will not say anything, he is lying. But a person who is conscious, who has got a bruise, he will tell you, Doctor Sahab, idhar aaye, bahut dard ho raha hai. You get my point. But your job is to tackle that patient first who has got an emergency, the conditions which are likely to kill him. So allotting priority is the most important thing, and this is called number one, primary survey and the simultaneous resuscitation. What did I say? What did I say? What is the first job? I said primary survey and the resuscitation of the patient. Please focus, pay attention to me. You have not come prepared, so a person who is not come prepared to the class, so mind has to be focused at least. So what thing we'll do first is primary survey and the resuscitation. I'll repeat it again and again so that it goes into your head. Primary survey and resuscitation. And let me tell you, whenever there is an injury, multiple injuries, 50% of the patient who meet the accidental injuries, out of 100 patients, 50 will die instantaneously at the site of accident. What did I say? 50% will be killed there and then at the site of accident. And a road traffic accident, severe injuries, right? 30% will be brought to the hospital and they die within first few hours, 1 hour. That is called golden period, we can save them. A person who is brought to us alive, he has sustained severe injury, he can be saved by resuscitation and surgery required. 20% are those patients who will die subsequently due to infections and complications, right? So in 100 cases, 50% will die there and then you cannot do anything because it may be severe brain injury or it could be injury to the heart itself and to the great vessels. By the time you go around, the patient is already dead. Rescued him. But 30% are the patients who have sustained injury. They have been brought to the hospital, and that period is the period which is called golden hour. Golden hour. First hour. You can tackle the emergency. He is bleeding, you can give him blood transfusion, you can give IV fluids. If there is airway obstruction, that can be managed. If he is not breathing, that can be managed. If he is bleeding, that can be arrested. So this is called the golden hour. We are after these patients, right? So this is covered under the head ATLS. ATLS. What is ATLS? ATLS. ATLS. Remember, I am hammering again in your mind so that you understand what I am talking about. ATLS. ATLS means Advanced Trauma Life Support. What is it? Advanced Trauma Life Support. So in Advanced Trauma Life Support, there is a first thing is primary survey and the simultaneous resuscitation, where you have to allot priority for resuscitation and surgery, right? And then comes your secondary survey, and then comes your tertiary surgery, tackling the specific organs. So let us focus today. I am going to talk to you, but I will tell you what are the things to be managed under ATLS and primary survey. But today I'll have to focus on airway obstruction. How to tackle airway obstruction. I've got so many things here, and we'll go to that and going on so. The first and foremost thing, whenever a patient comes to you, you have to see quick survey. You don't have time. So your team has to see, it's a teamwork. So managing traumatized patients is a teamwork, and team must have a leader. Without leader, it becomes a crowd. So he directs, and leader must be a person who is knowledgeable and experienced. He directs a person, elderly person with sufficient experience. He'll tackle it, whether there is a single patient or there are many patients. So firstly is the airway obstruction. A person who has got airway obstruction, go ahead, talk to him. Ask him his name. If he is unresponsive, he is not talking to you, then there means something wrong. So then you see whether his chest is expanding or not. Is he breathing or not? If he is not breathing, he is not responding to your speech or even to the pain, and you suspect that there is something wrong. Airway obstruction after the trauma. Airway obstruction. What could have happened? That you suspect has he got maxillofacial injuries, which are quite obvious. A person is bleeding, his throat may be choked with the blood. There may be blood clots inside. He might have been putting a denture, artificial denture. He might have swallowed that. His tongue might have fallen back, and it might have blocked the pharynx, oropharynx, right? So there may be some clothing, some blood, something of that kind. So that means, or even outrightly the person might have fracture of the trachea. So these conditions, when you suspect patient is not breathing, chest is not expanding, will demonstrate it. So airway obstruction is there, and he may have had injury of maxillofacial injuries also. So you must keep in mind that before you tackle the airway obstruction, you must exclude, remember, cervical spinal injury. Because if you figure around with a patient who's comatose and you start maneuvering his neck, if it is an incomplete fracture and there is no dislocation, the patient may have fracture dislocation because spine is fractured. Cervical vertebra is fractured. Now the person who was brought to you with an intact spinal cord may have transaction of the cord, now he land up with quadriplegia. Please, for God's sake, whenever you are seeing airway obstruction patient, you must exclude cervical spinal injury. And he requires clearance of the airway so that you can take appropriate measures at that time. What are those appropriate measures? His spine should not move. It should be under spinal cervical collar if possible. Or you can have sandbags on both sides so there is no abnormal movement. There is no flexion movement, things like that. So what you do is, don't do a blind procedure. Blind procedure means you are putting on the gloves, you have gauze pieces, and you try to clear the throat of the secretions and edema or blood clots or things like that. You can do like this also. What they do is, they put on the gloves and with the gauze piece try to clear. This is called blind, swelling, right? Going around and taking out the clots, things like that. No, you have to have, first thing, what are the procedures is this? One is a jaw thrust, which I will demonstrate to you. Jaw thrust. Jaw thrust means you lift the jaw upwards. Your finger should be behind the angle of the mandible. Your fingers should be behind the angle of the mandible, and then you lift it. This is called jaw thrust. If it is not possible, the second thing is you lift the chin lift. I'll demonstrate you this. So that will try to make the airway, accessible. And after that, there is jaw thrust and chin lift and tilt. You lift it up, but do not do such kind of movements in which the patient's cervical spine is compromised. And then, if there are secretion in it, you do throat suction. There is a suction apparatus, and we have got a suction tube somewhere here. This is the suction tube. You attach it to the suction apparatus, and if the patient's jaw is closed, then you will have to put the oropharyngeal airway. This is oropharyngeal airway. So this portion is upwards. This curvature, convexity is upwards. And what you do is, we have mouth probe also. The patient may clench his teeth, so you put an iron mouth probe in the teeth, and you try to open the oral cavity, and you pass this like this, right? And a person who has got a gag reflex, he will not tolerate it. That means he is maybe conscious of it. But this generally is used in those patients who are unconscious, so that quickly you have put it inside and you do the suction, throat suction, and clear the throat of the secretions, and then you can remove, under vision you can remove the clots also. So this is the oropharyngeal airway, right? Okay. This is called Gudel's airway. What is it called? Guedel, Gudel's airway. It is maybe of metal even, or it may be of plastic. You get my point? So this thing has to go so that this helps that a person's tongue will not fall. In a tongue falling back, the person will have airway obstruction. Is meant for that purpose. Is that right? This is called airway, oropharyngeal airway, you can say, Gudel's airway, right? And after that, you see, you have done the jaw thrust, you have done the chin lift, and you have put the oropharyngeal airway, we have cleared the secretions. So what are the causes of, what else you can do? You cannot put the patient on this thing till long time. You have to proceed further, and you have to do a definite management for airway obstruction. And a person who has got cardiac standstill, cardiac arrest, then you will be doing cardiopulmonary resuscitation. What will we do? CPR, cardiopulmonary resuscitation, which involves, will demonstrate the management. And in that event, you have to do the compression of the sternum for how much? 30 times you have to do it. And after 30 times, what you do is you have to lift the chin lift, and you have to give an artificial ventilation. You have to pinch his nose, and you have to exhale the breath. Two breaths, right? 2 breaths you have to do. Again continue with 30 compressions. Is that clear? This is one of the methods of saving the patient. And thereafter you can put an endotracheal tube, and meanwhile you can use this we used to call it Oxford inflating balloon. It's a ball well mask. I'll demonstrate to you there. You can use this also. You have put on, you have got an airway, you have already put the airway, tongue will not fall, and mask, this one mask you will put on the mouth and the nose of the patient. And this is connected to the oxygen. You connect it to the oxygen cylinder, right? You have done the suction, then you apply this thing, so that the oxygen will come and patient is not breathing, so you can give, and air should not leave. Is that right? This is called Oxford inflating balloon, or this is also called ball valve mask. This is called bagging. When you are going to oxygenation, the patient, it has to be regulated. It has to be regulated, right? So you have to achieve oxygen, this oxygen saturation. A person who is deoxygenated, what will happen to him? A person may be in shock, so his skin will be cold, very cold skin. His pulse rate, if he's in hypovolemic shock, or maybe having some kind of a respiratory problem. There's so many respiratory problems, there's so many things which affects the breathing of the patient, like pneumothorax, open pneumothorax, tension pneumothorax, hemothorax, flail chest, cardiac tamponade. We'll discuss it sometimes when we talk in detail. And after that, the first thing which you should be trained in endotracheal intubation. This is the endotracheal tube. This is the endotracheal tube. In the patient will come to you in the emergency, right? There's so many things. So it is a teamwork. One person, the anesthetist, will be introducing the endotracheal tube. Patient has no gag reflex, or he is semi-conscious, so he may not tolerate it. So patient might have to be given some kind of relaxation so that his jaw muscles they relax and vocal cords relax, and so that otherwise if you try to intubate a person whose vocal cords are tightly close together, so you may cause some kind of injury. So endotracheal, in a short neck persons who are short neck, endotracheal intubation is very difficult, right? So therefore there are so many. One is a retrograde method and antegrade method of endotracheal intubation. You know what you can do is you put a what you will call this thing fiber optic laryngoscope, and fiber optic endoscopy. What you do is you will be able to negotiate the endotracheal tube between the vocal cords. This endotracheal tube, once it has gone into the trachea, it should be above carina. You know where the trachea branches into two bronchi, right? So 1 to 2 centimeters above that. Otherwise, it will go to one side, the right side and left side of the lung will not get oxygenated. So endotracheal tube has to be intubated comfortably. You should not be in a hurry. And we have got the laryngoscope here. So there may be mouth probe inside. So when you open the oral cavity, patient is relaxed. So you are able to introduce the blade of the laryngoscope, lift the tongue up. Once you have lifted the tongue up, some assistant has to press so that the larynx comes down, comes down, and then you are able to pass the endotracheal tube. I'll have to remove one of these tubes. Generally, this has to be slightly flexible, all right, but you can have some kind of a wire inside, still it inside, so that it does not get folded, because once you are putting, this might get folded. So therefore, once you have lifted the tongue up and somebody presses the neck of the patient, and then you slowly go and pass this tube into trachea. You have lifted the tongue, you have lifted the jaw, right? See that, like this. You have lifted the jaw of the patient, you demonstrate it outside, and this goes into the trachea and through the vocal cord. Is that clear? Once it has gone through the vocal cord, then you have to inflate it. This is not a cuffed endotracheal tube. It should be cuffed endotracheal tube. In cuffed endotracheal tube, what happens is, this is for demonstration. There is a cuff here, there is a tube here, and you push the air into that, and this balloon here, cuffed endotracheal tube, this cuff will inflate, otherwise this will come out. You get my point? Once you have pushed the tube inside, the cuff has to be inflated. With a syringe, you push some air inside in the syringe, and this will get swollen up like this, and now it cannot come out. It's pretty snugly. It cannot come out. But if it's lying loose, it will come out. During 85, 87, I was in Siachen, so what we were doing, we didn't have an endotracheal tube. We are just IV set. The IV set we are putting inside, and then closing the larynx to a roller gauze. That's how we were operating in a very primitive condition and a bunker. Minus 15 degrees centigrade temperature. And we did not lose any person. But person behind the machine should be trained and experienced. This is an endotracheal tube. It is introduced when the muscles are relaxed, vocal cord is relaxed, and after this has to be, let me repeat again, this has to be inflated. The size is mentioned. Generally for adults it is 7 mm to 7.5 mm endotracheal tube you require. Once it is cuffed, then of course the air will not leak and you can proceed. But if you are unable to put the endotracheal tube, what can you do? Then you can do is you can put a small needle here. A person on the roadside who is not breathing, he is choked, you can do, if possible, you can put a small needle here. Precothyroidotomy is kind of a needle precothyroidotomy, and the patient, you can save the life. It has happened. You can simply put a needle here. When there is an airway obstruction, a patient will, you'll save his life. So, one is endotracheal intubation. And if you find that endotracheal intubation is difficult, then surgical, you have to do precothyroidectomy. That means you have to give an incision, and there is a tracheostomy tube. This tube is put, the cannula is tube, put inside through the tracheal wound, and that is how you maintain the patency. A person may come to you with tracheal injury, the fracture of trachea, that person will be having surgical emphysema. He will be swollen up, face and neck will be swollen up with the air. This is called surgical emphysema. What is it called? Surgical emphysema. So what I am telling you, the first and foremost thing is that you have to restore the airway. And person is not breathing, he will not be able to talk to you, whose airway is compromised. Obviously he cannot. And you have to ensure that airway obstruction, if it is because of the tongue has fallen back, or there are blood clots, or there are secretions, or there is a denture, so that can be managed, right? The second thing which I would like to talk to you briefly is the patient's airway is intact and he's not breathing. What is the cause? Patient is not breathing, airway is intact. The second thing, the person is not breathing can be because of injury to the lung itself, right? And what are these injuries where a person fails to have breathing is, there can be severe injury to the lung. And what injury can be that? There may be hemothorax. Hemothorax. Hemothorax means blood in the pleural cavity. A person who's having hemothorax in the pleural cavity is called hemothorax. If he has bled, because pleural space is a potential quasi-capillary space, so loss of 1500 ml of blood into the pleural cavity either side is called massive hemothorax. What is massive hemothorax? Blood more than 1500 ml in the pleural cavity is a massive hemothorax. Right? Or a person, you have put a drain and every hour you are collecting 200 ml of blood from the pleural cavity for a few hours. This is called massive hemothorax. So a person, if he has got bilateral hemothorax, what will happen? Patient is likely to die, so you have to do something. So the first and foremost thing is, the urgency is because of massive hemothorax will compress the lung. The lung will collapse. And if it's a massive one, the lung might affect the other side also. The other side is also affected, will be compressed. So naturally the person will not be able to breathe. So urgently you have to, sometimes the blood is clotted, you put a needle. It is mentioned in the books that you can put a needle, but very small amount of blood will be coming out. So you have to insert a intercostal tube drain. Intercostal tube drain with underwater seal. Remember these words I am telling you. So you put an intercostal tube drain which goes into the pleural cavity. You give incision, of course, local anesthesia incision, and this also should be placed in the fifth intercostal space. We used to put in mid-axillary line, but books mention that in the fifth intercostal space anteriorly. And this tube, once the blood is there, fresh injury is there, blood will come out. But along with the blood, if you do not put the end of the intercostal tube drain connecting to a rubber tubing under the water, there has to be a bottle in which the blood will be collected. So it should have water. If you don't have water in that, what will happen? Air from outside will be sucked inside. This will become hemopneumothorax. What will it become? Please take care. So whenever you are doing this procedure, you clamp the intercostal tube drain. I have given an incision. Under local anesthesia, I have gone into the pleural cavity in the fifth intercostal space or anteriorly on the right side. The left side, you have to take care of the heart also. So the safest point is fifth intercostal space. But right-sided, this intercostal tube drain, there is a lever. You must ensure that you are not injuring the lever. Otherwise, this thoracic injury becomes abdominal injury, and lever will also start bleeding. One has to be very, very careful while introducing the intercostal tube drain, because it has to, once you have done an incision, it doesn't drop, it has to go through the muscles of the chest wall, right, and into the pleural cavity. Be gentle, right? But it has, when you're doing this procedure, when you're introducing the intercostal tube drain inside the pleural cavity, it should be clamped. Where is the clamp? So that air doesn't go inside, connected to the underwater seal tubing, which has got fluid inside. So the blood will come out, right? And lung will expand. So this is hemothorax. Then what can happen in chest injuries is open pneumothorax. What did I say? Open pneumothorax. Person has sustained injury to the chest. What will happen? Because there is a negative space inside, the atmospheric air will be sucked in, and patient will have pneumothorax. There is air in the pleural cavity. There is air in the pleural cavity, and this open pneumothorax, it is a sucking wound of the chest. What is it? The sucking wound of the chest. It will suck the air inside from that wound, and the diameter of this wound is, if it is more than 2/3 of the diameter of the trachea. If the trachea is damaged, if the wound is more than 2/3 the diameter of the trachea, then of course the air from outside will go inside. Otherwise, tracheal job is to take air inside. But if the diameter is more, so what? How do you manage? You do a dressing, but keep this dressing open from one side. 3 sides you close it. आपके पास patient आएगा. You get a patient with sucking wound on the chest, and the air is going inside. Cover it on all sides except one side, and do an intercostal tube drainage from the other side. Right? So this is open pneumothorax, hemothorax, right? Open pneumothorax and hemothorax in case there is a bleeding there. This is called open pneumothorax, sucking wound of the chest. The other one is tension pneumothorax. What did I say? Tension pneumothorax. That means there is a lung injury. There is a lung injury, so air will escape from the lung into the pleural cavity. And this pneumothorax is characterized clinically. You can make out patient may have surgical emphysema. This chest wall you press it is swollen. There is swelling all over, and there is you press it. There is crackling sound. The air leaks out into subcutaneous tissue. It becomes swollen, and you press it. You have crepitus. This is called surgical emphysema. And one do the percussion, then you have a tympanic node. Otherwise, I am percussing my, the left middle finger with the middle finger, distal phalanx of the right middle finger to percuss. There is a dull node. But in case of pneumothorax, there will be tympanic node. Is that clear? So, in such cases, if it is tension pneumothorax, what do? You put a needle in the second intercostal space. This is the second intercostal space. This is the second intercostal space. In the mid-clavicular line, see here. This is the clavicle here. You know that. This is the mid-clavicular line. Put a needle there. And once there is air in the pleural cavity, what is that? Tension pneumothorax. Naturally, air from outside will not go inside. It will come out. Right? And thereafter, you can subsequently, put intercostal tube drainage. Tension pneumothorax, untackled, what you have, patient may go into respiratory failure. He may go into shock also. Is that right? And the other lung is also affected. Right? So that is compromised. So we just might shift to the other side, and patient will be having respiratory arrest. Then comes in hemothorax, you can have, I have already told you that there is massive hemothorax. So you will start in such patients. This is a teamwork I am telling you. One is looking after the airway, the other one is looking after, is putting in 2 cannula, 16 gauge cannula, 2 sides. If he's in a state of shock, what you do is you start pushing in IV fluids till the time the blood arrives for transfusion. Person with hemothorax, right? So in polytraumatized patient, one person will be getting intravenous access to push in the fluids, right? And what fluid you give? Crystalloids you give, crystalloids. Not the glucose 5% or something like that. You give crystalloids like saline or ringer lactate. What preferably in trauma, always make sure when you are bleeding and the patient is bleeding, start intravenous access with 16 gauge needle, push in crystalloid. Crystalloid means your isotonic saline, or it could be a ringer lactate also. And then one person is drawing the blood. Take it. So then examine the whole anterior part of the body, right? So next comes the flail chest. In flail chest, what is F-L-A-I-L? F-L-A-I-L. Flail chest. Flail chest. What happens in flail chest? Flail is an autonomy. Somebody, this is an integrated part, organization of various organs shaped into a human structure. So, it is not possible to act otherwise, or liver or spleen or heart or like that. This is a coordinated action. So therefore, what I am trying to tell you is that in flail chest, there are 3 or more ribs which are fractured at 2 sides. So this is the 3rd rib. It is fractured here also, it is fractured here also. There is a 4th rib, it is fractured here also, here also. 5th rib, it is fractured here also and fractured here. A rib which is fractured at 2 sides with three or more than three ribs, that means it becomes independent, autonomous. When the person breathes, it won't expand because it is fractured. So therefore, there may be paradoxical breathing. What may be there? Paradoxical breathing means when I am breathing inside, the chest expands. But in a flail chest, the chest will not, that particular segment is called flail segment, will not expand, but rather it will be indrawn. And the patient is conscious that that flail segment is being driven inside. During inspiration, it will press on the lungs and cause pain. So therefore, there will be, patient will arrest his breathing. So once he does that, he has got injury and he's not breathing just because, voluntarily he's not breathing because it pains, because of this flail chest. So there will be, patient will go into respiratory failure also. So what do you do for the flail chest? If you do some kind of a maneuvering, the person will not accept it, which gives it pain. In earlier times, historically, I am telling you what I used to do, because we have been trained in so many, you will be surprised, my training was very, very different kind of thing. I started off as an anesthetist. I was exposed to anesthesia. You know, and I was forced to go for anesthesia. There was some wisdom. In armed forces, there is a wisdom in everything. So that once I am posted to a battle area or something like that, which actually happened, then I realized I was trained in so many things. That subjected to neurosurgery also, was posted in neurology also, orthopedics also, reconstructive surgery also. Even in remote places, we have people living there, men, women, children, and things like that. So we were trained in doing cesareans also, cesarean sections also. So we were doing everything. At one place, I was given anesthesia also and operating myself also. So therefore, what I want to tell you is that a person has to be trained in all aspects. And in flail chest, what we used to do in our time, we used to do the strapping so that immobilize the segment. No, nowadays they say that segment has not to be immobilized. Why? Because if you immobilize that segment with plastering or with strapping, patient, you are trying to stop his breathing, right? Another thing what we used to do is the fractured ribs, we were giving the wound and suturing the bones. You're fixing the bones with the steel wires. So that, but this used to give good results also. So the treatment these days for flail chest is that you must intubate the patient, paralyze him, make unconscious, and put him on the ventilatory support. Okay? Till the time 5 or 6 days, you know, he will be able to breathe himself. So this is called flail chest. The another injury used to be, I told you about, there is it can be hemothorax, massive hemothorax, pneumothorax, tension pneumothorax, flail chest, and person may have cardiac tamponade. Person may have cardiac tamponade. Cardiac tamponade, even 150 ml of blood in the pericardial cavity can kill the patient. And how do you diagnose that person has got pericardial tamponade? There is blood in the pericardial cavity, so inflow will be reduced and his jugular veins will be distended. Person will be in shock, right? Patient will be in shock. Jugular veins will be distended, and there no heart sounds will be distant heart sounds. Is that right? So you have to remove the blood from the pericardial cavity. Okay. Now let's go to the place and let me tell you. This is the laryngoscope which is used for lifting the jaw. The person should be able to open the mouth, right? So you have jaw thrust and chin lift. The two things you should remember: jaw thrust and the chin lift. The jaw thrust can be demonstrated here. Once you have put this thing, the blade of the laryngoscope in the oral cavity and lifted the tongue, somebody, I told you, has to press the neck here with the precoil so that you are able to see the vocal cord. So once you see the vocal cord, push the tube. There has to be a steelate inside. The tube goes inside into the beyond the vocal cords, and then an assistant, when the anesthetist is holding this tube, he pushes air, the fitments are not there in the thing, and there is a cuff here at the distal end. So it gets distended, inflated, and therefore it cannot come out of the through the vocal cords. Is that right? And then you can carry on. This is called the laryngoscope. It is detachable. Now, if I detach it, the blade is detachable, and we should ensure that the cells are there inside. So there is a lens here. So it will light the oral cavity, and from outside also they will find the glow, the sign of a red glow you will find because of through the skin. And then it is accomplished. This is the adult laryngoscope. This thing can also get detached, and cell should be there, and you have pushed the blade inside, lift the tongue up, and put them into tracheal tube. This is the adult endoscopy. And what should be the size? Because you should remember when you go to the emergency, you have to ask. He'll give you vocal cords. The diameter is quite a but it will be 2 vocal cords. So therefore you have to tell him that what size. So 7 or 7.5. If it is actually a well-built person, you choose 7.5 to 8 mm diameter endotracheal tube. ETT. It mentioned ETT. It must have mentioned. This is size 6 here. Everything is given over here. This is endotracheal tube, ETT. And this tube can be passed through the nasal cavity also, which the patient tolerates it much better than the oral cavity. You should, whenever you are resuscitating the patient, if he has taken something, the food particle, milk or water, what he has taken, it will come to the oral cavity from the stomach. Particularly when you give it the compressions. And if you have not emptied the stomach, so therefore simultaneously, when you are resuscitating the patient, put a Ryle's tube also, feeding tube we call it, and aspirate the contents. What did I say? Pay attention, girl. Whenever you are tackling an emergency patient, patient may not die due to hypertension, may not die due to pneumothorax, may not die due to pneumothorax, but may die due to aspiration of the gastric contents. And this is called pulmonary aspiration syndrome, a fatal kind of a thing. Is that, I'm telling you that. You cannot save it. The person has taken full meal, there is a fluid inside, and he has aspirated into the lungs. What will have? Pulmonary aspiration syndrome, and it is very, very difficult. And once you resuscitate, no point, it has spread all over, acid digestion and everything, bacterial infection taking over, and patient is gone. So therefore, whenever doing primary survey, one person is seeing the injuries and things like that, the other person is putting IV line, one person is putting Pauline's catheter, another one is putting Ryle's tube and aspirating the contents. And once you have examined that, then what you do thereafter, you have to see the abdomen also. Today's brief does not permit me to talk to you about abdominal trauma and pelvic trauma, but we have to mention here that a person may have abdominal injury also. There may be liver injury, there may be skin injury, there may be perforation, rupture of the intestine, right? There may be pelvic fractures also. Once you have eliminated these things, once there is a fracture in the limbs, the person may fracture femur, closed fracture femur, one may lose 1.5 liters of blood. How much? And humerus fracture may, the blood loss may be somewhere around 7 to 750. You have to give these people IV fluids. You say there is no external injury, is not bled, but the fact is patient has blood inside. Maybe there is a pelvic fracture, maybe abdominal fracture, maybe there are retroperitoneal injuries to the kidney. So there will be retroperitoneal hematoma also, right? Once you excluded this, the next turn comes, what do you do once you have tackled this? Log roll. What is log roll? This question will be asked to you. What is log roll? I am talking to you practical point of view because I have worked with these pharyngeals also. Okay? They are very meticulous. They will not assign you any responsibility unless you know the job. And they will test you. If you say endotracheal tube, I don't know how to intubate. So what you will do, you stand there with the wash and stand like this. So thereafter you have to do, once you have tackled and seen injuries to the anterior part, then you do the log roll. And if you have got a spinal injury anywhere, doing log roll, you may cause dislocation of the fractured vertebrae, patient will have paraplegia or quadriplegia depending on the site of injury. So in log roll, what happens is the anesthetist controls the head. He will ensure that there is cervical spine protection is the most important thing. Cervical spine protection, that it should not get dislocated and cause spinal injury, that it should not result in compromise of the patency of the trachea, and thirdly, lung aspiration should not be there. So another one, we demonstrated there, is one stands on the right hand side, the other one on the left hand side, and both hands are behind the back and the pelvic region, and two person will be there on the leg side. So in one coordinated movement, they will turn the patient, turn to the left side or right side, whatever it is, and then examine the spine, right? There should be, one thing is there is a conscious, there is a fracture, there will be stepping. You know, you palpate the spine, and if there is a stepping irregularity, so you have to take control of it. Now let's go and see what we can do.